So it is now my distinct pleasure to introduce our first speaker, Chloe Pou-Prom, who is a senior data scientist in the Data Science and Advanced Analytics team at Unity Health Toronto, where she develops and implements advanced analytics models that improve patient outcomes and healthcare system efficiency. Chloe has been part of this team since 2018 and has worked on various projects, including developing an early warning system for general internal medicine patients and building a dashboard for monitoring COVID patients in the hospital. She is a master's in computer science from the University of Toronto and is a former vector researcher. Please join me in welcoming Chloe, whose talk is on deploying an early warning system in the hospital.
Thank you for the introduction, Joanna, and thank you to Vector for hosting this session. So let me just go ahead and share my screen. So as Joanna said, the title of my talk is Deploying an Early Warning System in the Hospital. So I'm Chloe. I'm a senior data scientist at Unity Health Toronto. So UHT encompasses 3 different hospitals in Toronto. So there is Providence Healthcare, St. Joseph's Hospital, and also St. Michael's Hospital, which is right in the heart of downtown Toronto, right next to Eden Center. So I work for the Data Science and Advanced Analytics team, and let's just dive in with my talk. So agenda for today. So I want to spend some time talking about the project background. I've tried to remove all acronyms because I know that in healthcare, people use acronyms all the time. So if ever there's something that doesn't make sense, feel free to shoot a question in Q&A. Spend a bit of time talking about model development, deployment, going over some preliminary results, and hoping to allocate some time at the end to talk about just data science and healthcare in general. But I'm sure there will be some more questions during the panel discussion later on. All right, so project background, basically what we want to do is we wanted to build an early warning system in the hospital. So here I'm focused more specifically at St. Michael's Hospital. So the question was, does the deployment of an AI-based early warning system and associated care pathways reduce in-hospital mortality among general internal medicine inpatients? So the whole scope of this project was really focused on general internal medicine. So there are different services across the hospital, for example, surgery and general internal medicine, or GIM, which I'll refer to throughout the talk. So for a bit of context, clinical deterioration in GIM at St. Michael's Hospital, about 8% of patients will die or go to the intensive care unit. And overall, this comes out to about 15 of these events per month. So you want to reduce these events. So the objectives, well, first of all, we want to develop an early warning system to identify these high-risk patients. And then we want to see if implementing a clinical intervention based on this early warning system would reduce mortality and improve quality of care in GIM patients, specifically at St. Michael's Hospital. So there are different ways in which we define quality of care, and I've outlined a few here. So one of them is, earlier notification to the intensive care unit team before transfer to the intensive care unit. So obviously, we'd like to reduce the transfers to the ICU, but sometimes it's not possible. And in that case, having earlier notification would be useful. Reducing ICU length of stay, less ICU use, better allocation of nurses to patients. So, you don't want to give all of your high-risk patients to one nurse. You kind of want to spread the load evenly. Better communication with patients and families about prognosis and goals of care. And in the case where we think that death is expected, earlier involvement of the palliative care team to have those earlier end-of-life discussions. All right, so for the model development, so what we did is we developed a model that would predict which patients were at risk of experiencing the outcome. And the way we defined our outcome when we were building our model was the following way. So it was a composite of these events, so transfer to the intensive care unit, death, or transfer to a palliative unit. In terms of the data on which we trained our model, so as I said before, we were focusing on general internal medicine patients. So we defined that as our cohort. So there were about 20,000 patients from 2011 till the end of our training period. And the data that we used was limited to labs and vitals. So like, your blood glucose, your heart rate, temperature, things like that, and also some demographic information. There are other data sources that are available in the hospital, but we focus on these ones because these are the ones that are pretty much commonly available in all hospital systems, in all kind of settings. So if you're thinking more long-term in terms of like generalizability, at least we're working with data sources that are readily available pretty much everywhere. And in terms of the model, we went with a multivariate adaptive regression spline model. So our model would take as input the lab's vitals demographics. It would output a score, and then that score would then be grouped into either high risk, medium risk, or low risk. All right, so we have our model developed. Now we can deploy. So the way that our model was deployed is we would have this model that would be running in the background, and every hour it would generate a prediction. So classify a patient as being high versus medium versus low risk. And when the patient was high risk, it would be flagged, and that would trigger an alarm. So a notification would be sent out to the clinical care team, so to the doctors, to the nurses, and to related teams. And once that alarm is sent out, that basically initiates your care pathway. So the way we set up our care pathway is this intervention checklist. So here I have a shorter summarized version of it. But basically what you're doing is you're reassessing your patient, you're checking their vitals, you're reassessing their goals of care, you're seeing if sepsis is involved, and you're thinking about involving potentially other teams within the hospital. So that would involve intensive care unit, critical care response team, or the palliative care team. So as I said, we would generate predictions every hour. So the different model predictions, we're basically classifying each patient that's in general internal medicine as being either high risk versus medium risk versus low risk. And there's different ways in which we're using these predictions. So one of those ways is to send emails to the charge nurses. So these are emails that we would send out twice a day, and it was usually kind of like before the shifts would start. And the charge nurses would use that when allocating nurses to patients. So making sure that you don't give all of your high-risk patients to one nurse, making sure that you're not giving high-risk patients like maybe less experienced nurses. And then, the other outputs were sending emails to palliative team, updating the database. So all this high, medium, low risk predictions would basically go to the database. That's mostly been used by the doctors. So when they're thinking of discharging a patient, they could just go through the front end view of that database. And if they see that someone's high risk, then they may want to kind of like reevaluate before discharging them. And lastly, we also sent alerts directly to pagers to some of the relevant residents and doctors. So basically they get their alerts to their pagers. I would tell them, like, hey, like this patient is at risk. You need to do something. Yes, this is an example of the alerts that were sent to the pagers. So basically, you give a patient's name, their medical record number, and they're a high risk of transfer to ICU or death. Please refer to the link. So we had a URL that was embedded for more information. And when people clicked on when the clinical team clicked on the URL, it would basically show like the more detailed intervention checklist. And I had a question about one of the intervention. Yeah, I had a question about the intervention list. I'm just going to address it now. So the question was, is the intervention list generated by the model or done by medical care team? So the intervention list was developed by the medical care team. So one thing I might allude to a bit later, but I might as well say now is that with our project, we work really closely with the medical care team, with the clinical care team. So they really developed this the intervention with us. Yes, so we've gone over the deployment. Let me go over a few preliminary results. So Chartwatch, which is the name that we gave this system. So our early warning system was deployed in August 24, 2020. So yeah, towards the end of 2020. And overall, it's been sending about 2 alarms per day, which is a reasonable amount. Like obviously this fluctuates. There are some days where you get no alarms, some days where you get more. I think the most I see here is like 6 alarms. But anecdotally, from speaking with the clinical intervention team, like that was a reasonable number for them and it was very manageable. So in terms of some results, so we start looking at mortality in patients. So here I'm looking at mortality in all general internal medicine patients. And the way I set up is I'm comparing different chunks of the year to the past. So for example, I'm comparing like July to September 2020 to the average of July to September from 2016 to 2019. This is to account for seasonality, because like there are some seasons where there's just more deaths. Like that's just how things are. Yeah, so the tool was developed in late August 2020, and then if we're looking at the October to December chunk, we do notice a slight reduction in mortality. And just for the units, I'm looking at the number of deaths per 1,000 discharges. So we notice a slight reduction in mortality. It's hard to say if it's actually due to the intervention or not, but I mean, it is pretty promising. And when we focus only on the high-risk patients, so the ones that were alerted or would have been alerted, that reduction in mortality is larger. So that's very promising. But also, I just want to highlight that these are preliminary results. Once again, this was deployed in August, and I'm only showing the results up to the end of 2020. We started looking at the results in 2021, and they're also very promising. But yeah, I just want to highlight this is very preliminary. But I think what we can say pretty confidently is like we're not causing any harm. I think one of the hard things about evaluation, and that's common in a lot of like data science in healthcare. There's so many factors that affect your health. It's hard to say if like this is caused directly by the intervention, or if there's like some other process changes. Like for example, COVID happened in 2020, so like a lot of our numbers will be affected by COVID. Oh yeah, and actually, I had a really good question. That was, what is the metric used to evaluate ML model performance? So for this specific case, we defined our primary kind of like metric of interest is really mortality. Like we want to reduce mortality. So that's kind of like our main goal. But you know, as you're evaluating your model, other things you can do is like the typical AUC, sensitivity, positive predictive value, and so on. But at the end of the day, you're really looking at mortality, because that is your goal, to make sure you have less people dying. And I had a question about whether the model was more or less like a prognosis model, and what other models we looked into. So we looked at a bunch of different models. We looked at a bunch of deep learning models. We looked at a bunch of more baseline models, and we ended up going with the multivariate adaptive regression spline because it worked well, and also because it was probably one of the easiest ones to deploy and work within our existing kind of like infrastructure and systems. So that kind of wraps up the project-specific side of things. I had a few slides at the end that were related to like data science and healthcare. So yeah, I guess some of the lessons learned from this project, which is still ongoing, but also some lessons learned overall from data science and healthcare. You know, model development is only a small part of the project. Throughout the project, you'll have engagement with different stakeholders. That's really essential to get things moving and get things implemented. And also evaluation is hard. A little bit about what data science role in healthcare is like, but I might actually dive into this a bit deeper in the Q&A and the panel discussion session. So yeah, lots of collaboration with different groups, you know, working with IT, working with clinical end users, working with clinical informatics. A lot of time will be spent as a data detective, you know, figuring out what's wrong with your data, figuring out why things aren't working properly. I think that's common across most of data science. Deployment, this might depend on the size of your team and how well you guys are set up, but I think most of the data scientists in our team had to spend a lot of time kind of like infrastructure and doing a lot of software development. Research opportunities, I think that because data science and healthcare, there's a lot of interest from the research side. So we have close collaborations with the U of T and Vector for some of our projects. So there are definitely some research opportunities there. And there's always a lot of interest in, you know, machine learning in healthcare. And then very quickly, how does my role fit into the rest of my team? So DSAA is split into different groups. So, you know, there's the advanced analytics team where I'm working on, but we also work closely with the data integration governance, which, you know, takes care of data, product development, which is a newer team, but they're the ones who are really in charge of basically bringing things up to production level standards, developing any dashboard, developing any tools. and the support team, which is in charge of coordination and like the project management side of things. I think one thing that's neat within our specific team is that the projects are really driven by our clinical collaborators. So like the whole implementing an early warning system at the hospital, that came from an internal medicine resident. He told us like, hey, like this would be something that would be really useful for us to have. And I think it makes sense that this is driven by like your clinical collaborators, because like as a data scientist, like I don't see how things are on the floor, for example. Yeah, just a quick note about different responsibilities as a data scientist. So, you know, you're working on different things: project planning, understanding, data exploration, preparation, investigation. You'll spend a lot of time there. A significant amount of time in modeling, also a lot of time on evaluation. Okay, so I say I've just gotten a bunch of questions. So let me see if I can go through them.
Yeah, it sounds good. So why don't we pick one or two to go through, and then Chloe, if you have time, maybe during the other talks, you can answer some of them in the chat if that works.
Okay, yeah, for sure. Sorry, a lot of these questions are pretty long, so.
Okay, maybe I'll just pick a random one. So is the updating of the database and changing of nurse duties done as a result of the model, or is the alert verified by doctors before making those decisions?
So this was one of the things that kind of like the clinical team had hoped would happen. They had hoped that they would use kind of like those updated risk groups to help with nursing assignments. So as we were checking in with the nursing team regularly, we were asking like, hey, like, are you using this? Are you using that? And like, we kind of like got that confirmation, which was good to hear.
That's great. Okay, and another question, was the model or system able to generate any type of explanation as to why a patient was flagged as high risk, or was the model output more of a black box in nature?
Yeah, the model output was really a black box. Like obviously we could go back and look into the explainability, but from the way we wanted it to be, we wanted to embed seamlessly within the existing workflows. So we don't want to like create a new dashboard, create a new view that the doctors have to use. So it's just like, you know, you get an email at the same time as you usually get your emails, you get alerts to the same system you usually get alerts to. So we didn't want to embed the explainability aspect into that.
Great, thanks. And someone was wondering if the model is static. So once the model has been built based on historical data, the model is no longer developed and it can be used for future data, or is it more dynamic where the model is developed and changes over time as more data is fed into the model each day?
So I think it's dynamic in the way that we are generating predictions over time, but it is static in the way that we trained it once and we haven't retrained it yet, which is actually like a big thing we're thinking about, because as you're retraining and you want to use data from 2020, you've had potentially interventions, right? So you might have alerted someone, and then as you intervene, you prevented a death or you prevented an ICU transfer. So you definitely have to think about this feedback loop problem, which I think is common in a lot of these kinds of deployed approaches. But that is definitely something that we're currently tackling and thinking about a lot.
Great. Thank you for all your answers to the questions. I think that's all the time we have for now, but thank you for your amazing talk, Chloe.